Good morning, squad. Let's get things fired up here. So I have YouTube, Instagram. Instagram gets a little bit of the under chin, less flattering angle, but I'm trying to stack them this time so it's not so back and forth. This is, as you know, the PT on Ice daily show, and it's another DN day, another dry needling day. If we haven't met, my name is Paul Kaloran. I'm jumping on as the division lead for dry needling. Super excited to bring dry needling to the culture and the faculty and the mindset of ice. We have courses coming up. We'll talk about that at the end. But I was on here a few weeks ago with kind of the clickbait title of like dry needling doesn't have to suck. And I tried giving kind of these 30,000 foot view, these general recommendations to make it more approachable, more tolerable, and ultimately more effective. So today I want to go a little deeper, give you or be a bit more tactical, and again, try and give you kind of 2 to 3 recommendations when it comes to the dose of dry needling. Maybe you've heard the conversation or dry needling in the context of dose, or maybe you haven't. But I think number one, again, I'm going to try hitting 3 big points today. Number one is let's appreciate that there is a dose. So let's know that there is a dose to dry needling. And what that immediately implies is that there is a dose response to dry needling. So we're immediately talking effectiveness or ineffectiveness. And the best analogies here are, we can say that a joint mob is a joint mob, but all of us know there's grade 1, there's grade 2, 3, and there's grade 4. I want to put dry needling in that same context with that same mindset. And same goes for loading. We know we have body weight on our door frame isometrics, then TheraBands ankle weights, and ultimately we're using barbells. So I think dry needling, because it's kind of born out of this black and white, palpate here, needle here for the sake of safety, I think it kind of stays in this light of like, well, a needle is a needle, and there is no dose to it. And that's what I want to talk about today. And I will say that today, when I say dose, we're essentially saying mechanical dose or tissue trauma. So that's kind of how we use each needle, the pistoning or whatever techniques we use with the needle. That maybe goes into number of needles on a specific session. But we could also say that E-stim with dry needling has a dose as well. And I think that'll be a topic for another day. I mean, that gets into the parameters of duration, intensity, pulse width, frequency. So that'll be kind of a future show, the dose of E-stim for dry needling. But today we're just saying mechanical dosage, disrupting, traumatizing tissue with a needle, number of needles. That's the dose we're talking about. And again, the first thing we have to do is say, okay, there is a spectrum. There is a dose to needling, and there's a direct dose response to how we use that needle. So just to put a few buoys in the water here, let's say that on one very conservative end of the spectrum, again, dosing, needling, tissue trauma, mechanical disruption, is just static placement of a needle. Maybe we're in a muscle, maybe we're not, but we're just placing a needle. And I'm not here to say good, bad, or ineffective or not immediately, but I'm going to say the rationale there is kind of homeostatic, maybe nervous system calming, maybe local erythemic tissue changes around the needle, but very little to no tissue trauma. Like, let's place the needle. If we want to say that's kind of more the traditional acupuncture, I think that's fair. But that's one end of the spectrum, just tiptoeing, sneaking a needle in, leaving it, backing away. Maybe we do some deep breathing. Maybe there's spa music in on the background, and that's great. The other end of the spectrum, again, in terms of mechanical dose, tissue disruption, is pistoning. And maybe not just pistoning for the sake of 1 or 2 twitch responses. It's pistoning until twitch response exhaustion. Maybe it's peppering tissue. You read about research where they pepper an Achilles tendon for 2 minutes straight, mechanical disruption of the Achilles tendon. Not a comfortable experience. And yeah, if we talk about tissue trauma, it's significant. We cause an inflammatory response. Maybe that's the goal, maybe it's not. But again, putting some buoys in kind of homeostatic, superficial, gentle placement of a needle versus aggressive pistoning. And in a minute, we'll talk about the bell curve that lives in between there. But for now, we're just saying there is a spectrum. And we'll talk at the end about how maybe different patients, different intents, different diagnoses, we intentionally want to be at one end or the other. But right now, we're just saying buoys in the water. There is a dose to dry needling. And if you ever have been needled, or you needle yourself, I think the best examples that come to mind as far as kind of a lower, more conservative dose versus a more aggressive dose, think of your upper trap needles, your deltoid needles, your medial gastroc, the very reactive tissues where even if you say you subscribe to the pistoning or the Hong in and out is what they call it in research, if you subscribe to that model, we know that there's a big difference between eliciting 1 or 2 twitches or 20 twitches in those tissues. And again, I'm not here to say never do this, never do that, but we have to say there's a big difference in patient experience. There's a big difference in those 2 doses that I just mentioned. And again, I'm saying there's a big difference in the dose response to those 2 applications. So really, that's the first boundary I want to set, is there is a dose spectrum, how we apply the needles. Again, I think you could very easily say number of needles goes into that algorithm of dose. And number 2 and 3, I want to talk about when maybe we do a lower dose and when we do a higher dose. But 4 to 5 needles versus 12 to 16 needles, I think that could easily go into the dose equation, dose algorithm as well. So if we make it a little less linear, I just said there's a spectrum, point A, point B, there's kind of that spectrum in between. Let's make it a little more 3-dimensional and say there's a bell curve. On one end, again, it's that very conservative, that low dosage as far as tissue trauma, mechanical disruption. And then we have the more aggressive side. If we take the very extreme ends of that bell curve, we have to say that there is an underdose potential and there's an overdose potential for dry needling, the very far ends of that bell curve. And I guess the caution and the fear of both is, well, it's being ineffective. But let's say the low dose end of that bell curve, not only did we not use our needles enough to be effective, like there's no effect at all. And I guess the analogy here is we're doing grade 1 MOBs when it needs a grade 3 or a grade 4, or we're using our TheraBands and ankle weights when we needed a barbell. Again, think of dry needling in the same terms. On the left end of that spectrum, we just underdosed the needling. We see this a lot with brand new needlers. Maybe it's a personal anxiety. I mean, you've never used needles before. Now you're using it. So you're a little more timid, a little more tentative with how you want to use the needles. And I do think when you first start needling, that tentativeness or that anxiety leads you to underdosing. You're just afraid to cause any muscle soreness. You're afraid to cause an uncomfortable experience to your patient. So you'd rather just, maybe slip a needle in, take it out. I hope it helps. If it doesn't, at least it doesn't hurt that much. Which, I mean, maybe that's the conservative, the safe, like the risk adverse approach to take when you first start needling. But it is ineffective. Again, I think if you put it in the context of the MOBs and the loading, you might not have had the effect. And we have to discuss that if maybe it's a patient trying dry needling for the first time. If we don't give them, if we don't have demonstrable change, if we don't give them a high enough dose to impact change to benefit them, that's a disservice to the patient. We need to be confident enough. We have to know how to effectively use this tool. And if it's something personal with us, something with the patient, or just how we approach the needle, how we use the needle, and it's being ineffective, we need to know that we have to go a little higher up that curve of dosage. So that's the far left side. That's the underdosing of dry needling. The overdosing, you probably already can picture when I say upper trap deltoid medial gastroc. The overdose is patient's first visit. You kind of explain dry needling, you explain this twitch response, and you then go in and elicit 10 twitch responses in upper trap times 2, both sides, and that's the treatment. And for a first experience, you may have just overdosed that patient. And again, if we just say tissue trauma or patient experience, patient soreness, post needle soreness, and what that does for even the willingness to attempt it again as a patient, we've just overdosed that patient. And again, if we want to use the MOB manip analogy, maybe you're manipping a patient where it's not appropriate. Maybe you're manipping an acute condition. If you want to use the load analogy, you just gave that patient way too much load, and either they're going to hurt themselves or they're now frustrated that you gave them too much load. They can't do it. They haven't built the capacity, and we've just overloaded, overdosed, overwhelmed that patient. So those are the two ends of the spectrum. And I mean, this bell curve means that's the minority. I don't think that the majority of us are out there underdosing or entirely overdosing our patients. But we have to appreciate that within that bell curve, you can lean to one side or the other. And really, that's the nuance. That's kind of the expert mindset. The expert skill is knowing when it is appropriate with this patient, this diagnosis on this day, that maybe we can get away with a slightly more aggressive, a slightly higher dose to needling, and when we should back off and have a lower dose. That sliding scale of the bell curve. And now let's say, to be fair, we're in the bell curve of effectiveness. If you're kind of not drastically underdosing, drastically overdosing, largely if dry needling is an appropriate modality, it's going to be effective. There will be a positive change. But within that scheme, I want to move on to number 2. So the first recommendation is know there is a dose and a dose response, which sounds obvious, but I think sometimes we don't put it in that mindset as MOBs and loading. So number 2, if you're saying, okay, I haven't thought of needling like that, what's your point? Like, what's your recommendation? Number 2, I want to give you a pretty specific recommendation, and that is on a first or second visit, like on that first interaction, as we're kind of building that rapport physically, building some confidence in not us as a clinician, but dry needling as being a treatment option. We have to get really good at finding an effectively low dose. I'm saying that's where you want to start. Visit 1, whether they've had needling or not. And if they have had needling, was it a positive experience? Was it a negative experience? Because I mentioned this last daily show, is dry needling at this point is an umbrella term that has all sorts of different approaches, methodologies, and that translates to patient experience and clinical effect. So what I mean by that is patients are at this point going to come in and say, I've had dry needling before, and then it goes one of 2 ways. I've had dry needling before. It was awesome. Let's do it again. Like, I hear you dry needle. Let's do it again. Or I've had dry needling before. Don't even bring it up. Like, you're not approaching me with that needle. It was so bad. It was horrible. I'm not here for needling. Either way, we kind of have to unpack. It's like, okay, I appreciate what you're saying. Can I unpack this a little bit? Like, ask a few questions. What was it like? How many needles went in? Were they aggressively moving the needle? Did they use e-stim? What did you do after? I mean, all of these questions, we're trying to get a subjective, picture of what that treatment session looked like. But all we're trying to do is calculate that dose. And in our mind, they hated it because they were completely overdosed or underdosed. It's like, yeah, I tried it, but it wasn't really effective. Maybe that was underdosed. Yeah, I tried it. I was sore for 2 days. No, thanks. Maybe they were overdosed. What we're trying to calculate is what was their initial dose? Was it effective? And is what I'm planning to do similar or not? But I will tell you, if it's a patient now that hasn't had experience with needling, we as the clinician have to be pretty good at prescribing an effectively low dose. And what that looks like and sounds like is, you know what, Gladys, thanks for coming in today. I know you're coming here because your friend said They saw me, they had success with needling. We just ran through my evaluation. I do think dry needling is worth a try. And this is what it's going to be like. And maybe I'll say, Gladys, like at this point, it might make sense to needle everything from your lumbar spine to your posterior hip to your hamstrings, like that sciatic path. That could be like 10 to 12 needles. This is your first time dry needling. So I think I'm just going to pick like 2 to 4, maybe 6 spots. We'll see how it goes. Because on this first session or two, I want to kind of know what the most effective low dose is. Meaning, if we put it in the other context of, it's awesome if you put 20 needles in Gladys on visit 1 and she feels better. But even if she does feel better and she comes back, guess what? Next visit, you're doing 20 needles again. And maybe she's feeling so well, you don't see her for a little bit. And she comes back a few months later and you have to do 20 needles because that's what helped last time. For lots of reasons, we need to have an effective low dose strategy. So effective is key there. I'm not saying be ineffective. I'm not saying set the dose so low, like do grade 1 MOBs when you need a grade 3. That's not what I'm saying. I'm saying do enough to have a change, have an effective but low dose. I mean, some of the obvious recommendation or obvious statements, I should say, you can't take a needle back. I mean, if they get off the table and you're like, yeah, I shouldn't have pistoned that much in upper trap, or I shouldn't have done those last few needles. Like I thought we were doing pretty well. And I think those last 2, we kind of went past a patient threshold. You can't take a needle back. So I'm giving very tactical practice advice on how to be effective or not, but this is also good business advice. If you want patients to come back, don't even trend towards overdosing them in the first few visits. In my mind, sometimes I even tell my patients this, I'd much rather you come back visit 2, 3, 4 and feel like, man, I wish we could have done more last time. Like it felt good. I see the change, but I wish we could have done more. I'd rather have you say that and feel like that than, it helped, but it was a lot. Like it really took a lot of mental fortitude to get back in the car and come back today. Like I self-medicated myself to come back, but I'm on board. Like that is an overdose right out of the gate. So if you're talking about the best strategy early on, visit 1, 2, really whether they've had needling before, but especially if they haven't, we need an effective low dose. And the last point I want to bring up is the dose should change. Patient A, patient B, patient C, day 1 versus day 5, week 1 versus week 4, the dose for dry needling should change. And again, I think when I say it in the context of everything I just said, it's probably a pretty agreeable statement. But again, I think for some reason, and I think it's just when you're first trained in needling, the focus is so much on just be safe, just get the needle in safely. So to some degree, a needle is a needle. A needle in gastroc is a needle in gastroc. And that initial kind of safe education mindset kind of leads you into, okay, everyone who comes in with Achilles tendonitis, plantar fasciitis is going to get the same needles, and it's going to look pretty much the same. There's no dosing strategy at all. It's saying like, okay, let's do this. Take your aspirin. Like every patient is going to get the same amount of pistoning or not. We have to have a deeper, more patient-specific, more tactical mindset. And the first analogy I'll give you is the same patient, intra-patient. Let's say it's an acute ankle sprain, truly in the acute phase. You're seeing your athlete the day after it happened. We have a true active acute inflammation. This is actually going to be the topic for, I'll be back with you all next week. We have another dry needling day next week on the PT&I show. I'm going to talk about how to use needling for acute injuries, and specifically acute, subacute, remodeling, return to sport, and how we use it differently. But just to paint the picture of what I'm saying now, I'll explain to the patient of like, yeah, this is a grade 2 lateral ankle sprain. The swelling, the redness, the pain, the limping, everything right now is normal. I mean, the first phase of healing or the first normal response to an ankle sprain is pain and swelling. So, today my goal with my needling is not to decrease your pain. It's not to immediately evacuate that swelling. That's all normal. I mean, when you come back in 2 or 3 days, I'm going to start saying some different things. But right now, maybe we can do some needles, lumbar, spine, posterior hip, maybe even hamstrings. We're just going to use E-stim. And really the whole idea is to get a regional or an extremity specific pump. Like, we don't want to put needles right in the neighborhood of where the trauma was. Like, we don't want to traumatize that tissue further, but we can still use needling. I know we're going to go into what is appropriate for that. I mean, I think we're getting away from the Rice's strategy and more towards loading, a controlled load, controlled movement, resistance right away. But I mean, dry needling specifically, that's what I say visit 1. And I mean, a grade 2 injury, that true acute phase, it's less than 2 days long. So they come back, that happened on Monday. They come in on Thursday, and everything I told them, it's not a lie, but now I'm like, this looks great. You came in the day after your ankle sprain. All of that acute inflammation was normal. Now we're kind of getting into the subacute phase. And here's what happens in the subacute phase. Now all of that accumulated like cellular debris and fluid, like that localized edema and swelling. Now we actually do want to start evacuating that, because the next phase is tissue remodeling. It's by far the longest phase, but by far the most important. So we want to set this ankle, those tissues, up for success in the subacute phase. And what does that mean with my needles? It means I'm getting slightly closer. Now, maybe if it was a lateral ankle sprain, I'm not going to needle peroneus brevis, maybe not even longus, but I can pump the calf, gastrocsoleus. I can treat anterior compartment. Now it's a much more, not just a proximal or regional or extremity-based approach. Now it's a very regional, local, like pump the region without directly needling the traumatized tissue. So you see how the dose changed from visit 1 to visit 2, acute phase to subacute phase. Then they come back 2 weeks, or I mean, we're still seeing them, but 2 weeks later, it changes again. Now the scenario is, you know what? It's awesome. The swelling is gone. Your pain is getting better. Even when I test your range of motion, it's getting better. That's awesome. But we're still kind of in the early phase of tissue remodeling. Like, now the goal is just building resilient tissue, like letting this tissue restore itself. It's a topic for another time. This is immediately when I go into, one of those big protective responses from your body after that ankle sprain was your brain, your central nervous system. Like, however you want to infuse your pain science of maladaptive somatosensory changes. But I sprinkle that in there. So when I say, man, it's cool, now I can start needling peroneus brevis, like show them on the app, peroneus brevis was directly involved with this. There's a lot of good reasons why we want to needle. It improves mobility, decreases pain, improves recruitment. But man, we need to start putting some very precise input into some of the brain maps or into the central nervous system that may have smudged or changed a little bit. And we can get more and more aggressive with our dry needling dose the further we trust the health or the remodeling of that tissue. And now we fast forward to return to sport. Back to the initial 0.3, the dose should change. Hopefully we're not relying on needling as much with return to sport. I think if we're saying we start with an effectively low dose, and then maybe our dose increases throughout plan of care, eventually we'd kind of want to taper that dose as well. It's tough on the business side. If a patient says, man, dry needling is the only thing that's helped me, I want to schedule once a week for the rest of my life. I mean, it's tough in our business brain to say, well, if you do these 2 exercises, I shouldn't need to see you for the rest of your life. Like, let's think like 4 weeks. But I mean, that's how most of us think. It's our physical therapy. It's our sports medicine brain of, there's an end goal here. There's like if we can increase your capacity, build some tissue and human resilience, I'm always here if you need me, but you don't have to come in and see me every week. Certainly you don't have to come in and lay down and take needles every week. So when I say the dose should change, in my mind, I think the perfect course of care is you start with an effectively low dose. It's like, man, Paul, that was pretty cool. I was a little nervous. It wasn't nearly as bad as I thought it was going to be. It feels a little better. If you're saying you think you can do a little more, then maybe let's do a little more next time. I love that visit one. Then you do a little more. It's like, wow, this is so powerful and cool. Like things that I didn't even think were bothering me are feeling better. That says we get up. And then as we get more into like the load application, getting away from our needling strategies, it's like, okay, what can we do? This is the patient talking, I guess I should say. It's patient voice right now. Can we just do a few needles? Like I know most of the time is going to be spent out in the gym, but let's just do a few needles if that's cool. And at some point, it's, you know what? I don't know if we need to do needles today. Like you want to give it a try without needles. And when they start nodding, to me that was the perfect trajectory of care. And I'm not saying it's always that easy, but the dose should change. So far, the 3 challenges I've given you. Number 1, know that there is a dry needling dose. Again, if you haven't put it in that context, in that mindset, we should, because there is a dry needling dose and there is a dry needling dose response. And that can be good or bad side effects. That can be intended or unintended. But we have to appreciate that you can underdose needling if we're not effective, if we're too conservative, and we can overdose needling if we're too aggressive. And then even that bell curve in between, like there are certain patients, there are certain conditions where we can skew that bell curve. It's like, well, yeah, they're pretty healthy overall. This is not a highly sensitized, highly irritable condition. We can maybe lean a little bit more, a little higher on the dosing spectrum, versus the opposite is like, this is a relatively acute injury, or this is a highly sensitized patient or nervous system. Let's just back off. Let's just slide down that dose scale 1 or 2, at least to start. And I mean, I was going to give like patient scenarios, patient A, patient B, but I hope when I say this kind of stuff, you can picture it. And I mean, I didn't want to offend anyone either, because I was thinking like patient A is like that grizzly, like 60-year-old farmer. I mean, he's never complained about pain in his life, but he's a train wreck, both tissue function wise. But this is the guy where you can dose pretty heavily. He's falling asleep on the table as you're pistoning his glute. You have to wake him up when you're done. I mean, that kind of response. And I'll tell you, that's trophic changes tissue wise, but there's a lot going on, good and bad, cortically. Like that patient is tough to overdose, versus the opposite. Highly sensitized. Maybe it was a motor vehicle accident. Maybe it's an acute low back. It's challenging. They don't even want to sit down because it's so painful. They have a lateral shift. It takes you 10 minutes to get them comfortably prone or side lying on the table. You can barely light touch them. Like pain pressure threshold has plummeted. Like that kind of sensitivity. I hope you're thinking, you know what, 2 to 4 needles this session. If we can use our stim or whatever we can do to get that pain from 10 out of 10 to 6 out of 10, that's the goal. Like I hope those 2 patients give you a different dose strategy. But that dose response also has to have a pretty specific intent. And what I'm trying to tie in here is you should be able to communicate the dose to the patient, communicate the intent to the patient. And I mean, the other patient example is the CrossFitter of like, you've seen them previously for an injury, shoulder pain, low back pain, and they come in not for pain or not even to improve function or mobility. Now it's just kind of a recovery session. This is a topic we cover heavily on both our upper and lower quarter dry needling courses for ice. We can use needling and e-stim for recovery. We're not necessarily trying to decrease pain. We're not trying to improve mobility. And with that goal, we need to communicate is like, you've had needling before. Remember when you came in for your low back pain? This is how we use the needles. This is how many needles I did, or this is how I use the e-stim, because my goal is to decrease pain and improve movement. Right now, that's not our goal. So the needling is going to feel a little different. The e-stim is going to be a little different. Right now, we're just trying to pump muscles, improve fluid exchange, stimulate some nervous system responses. So it's not going to feel exactly the same as it did before. And you know what? I don't think you're going to get hurt. But if you come back, the recovery mode or the recovery application, it's going to be different each time. So being able to communicate that to the patient is important, what your goal is, but also what the dose is. And again, the example I gave earlier is it's that patient's first time. maybe it's chronic back pain, maybe it's radiculopathy. And I just am very honest with that patient to say, I think dry needling is worth a try. In my mind, I think we eventually might get to 10 to 12 needles. Like, it might make sense to treat L4, L5 multifidus, glute max, glute medius, glute minimus down the sciatic path. Like, all of these are kind of the list of muscles in my mind that might make sense to treat. It's your first session. So I'd really like to start with the glutes, or I'd like to start with the lumbar paraspinals. And again, everything I mentioned I kind of want to know, first of all, how you respond to needling, but I really want to know what is the most effective low dose. Again, I'd much rather have you come back next visit and say, I think we can do way more, versus saying, I think we did way too much. And that's how I want to put a bow on this session. Know there's a dose, know there's a dose response, and be able to communicate that to your patients. And that's how I'm going to wrap up. Last time I didn't take a look at if there was any questions popping up, so I'll take a quick look. Otherwise, I know the majority of you guys are catching the recording here. Again, my name is Paul Caloran. I'm jumping on as the dry needling division lead with ICE. Super pumped. We actually do have courses. We initially were just going to start courses 2023, but we got pretty excited and we found some eager hosts, and we have a few courses end of this year. So if you want to be one of the first on, we have an upper and lower dry needling course. Both are introductory. If you have taken a course, if you haven't taken a course, check it out. We cover pain relief, athlete recovery, neuromuscular recruitment or muscular changes using eStim. We hit all the key players. Lower quarter, we do TL junction down to the lower leg. Upper quarter, we do the entire C-spine to the forearm. So if you want to jump on one of the first few courses, I'm looking at you, Florida, Oviedo, Florida. We have Hendersonville, Tennessee, Milwaukee, Wisconsin. We're going to Frederickson, Maryland. But check out some of our upcoming courses. Otherwise, I'm jumping back on next week. I'm really just taking any openings I can see to dive into some of these dry needling topics, meaning it won't always be a Tuesday. But next week, Wednesday, is going to be another DN day, another dry needling day for PT on ICE. One more look for questions. Appreciate you guys jumping on. If you're catching the recording, you want to send us any questions, just drop it in the comments on social media. Have a great day, guys.